Well, now that we've got our neurologic system down, let's talk about neurologic disorders. So you'll be hearing a lot of repetition, and hopefully a lot of these disorders will start making sense because you'll go, oh, I've heard that word before. I know what that means. So let's get started here. And this is just the lesson plan. I've been saying these lately because it's kind of what the slides in the book want you to know. So pathophysiologic conditions, signs and symptoms, complications, and medical or surgical treatment for patients with selected neurologic disorders. So the ones that I'm going to be talking about in this chapter are specific, and there'll be more to come in the next chapter because there's a lot of neurological disorders. So we're also going to talk about nursing care plans in the neurology. So that's really helpful for you in your clinical setting. So first thing we're going to talk about is headache, and that's the first thing in your book as well. So I will be following the book. I will be using the book as well as the slides. The slides are pretty verbal. I mean, they have a lot on them. So it will behoove you to look at the slides as well as look at the book. So headache is the most common type of pain. In fact, a lot of doctors' visits are headache and back pain. So it's a symptom rather than a disease, and there's different types of headaches. First one I'm going to talk about is a migraine. Maybe some of you have had a migraine before. It's pretty awful. Intracranial vasoconstriction followed by vasodilation. There's no single cause, it's unilateral. So what that means is that it's on one side. Now, I know I used to get them. I would get it over my right eye, and it would just be so intense. You'd just be holding that one side of your head, and it would just, maybe you'd have nausea and vomiting, maybe you'd take some medication for it. Maybe that it's doctor prescribed or over-the-counter type of medication, and some of the medication had caffeine in it because of a vasodilation, the vasoconstriction followed by vasodilation, and then we know that caffeine is a vasoconstrictor. So once you get that headache, that migraine, sometimes caffeine would help. Another type of headache is called a cluster headache. And you have no warning signs with that. A migraine, a lot of times you'll feel it coming on. It will be slowly over that one side, and then it will get more intense over the days. But a cluster, no warning, just a period of intense pain, and it's usually related to stress. One thing I will say with headaches, if you have bright lights, it makes it worse. So that's like photophobic a little bit. You have photophobia. So low light usually helps the headache. Next type is tension headache. That's due to prolonged muscle contractions, various reasons, and you may also have nausea and vomiting with that. All right, so the next one is seizure disorders. And a seizure disorder, seizure activity involves many hyperactive neurons that use excessive oxygen and glucose. Therefore, oxygen and glucose stores may be depleted with a seizure disorder, and that could lead to permanent neurologic damage. So a seizure isn't a light thing. It's nothing easy about that. It's not something that we look at lightly. So electrical impulses in the brain are conducted in a highly chaotic pattern. So we see that on an EEG because an EEG is the electrical activity in the brain. So we would see that. I will tell you something interesting. At UCSF, they actually have a seizure wing. And when they have someone with a seizure disorder, but they don't really know what medication would be best for them. So maybe some haven't worked, maybe they haven't been under control. So they close the doors, and it's almost like torture. because they put bright flashing lights, they put loud music, they don't let you sleep. They do a lot of things trying to bring on a seizure because they want to see that EEG, which part of the brain is affected, what medication can we give the patient to help them with that seizure disorder. Now, there are different types of seizures, partial and general. There's a condition called status epilepticus, and that can be a medical emergency. And it's because it's repeated seizures in rapid succession. Well, if we already know that it depletes the brain of glucose and oxygen, well, what if that rapid succession of seizure activity doesn't give you a break and it doesn't give you enough time to get glucose and oxygen? So it can be a medical emergency. I have here aura. So an aura is a sensation that a person might have or feel or see prior to having a seizure. It could be a smell. They smell something or they see something, and that will bring on, they know a seizure is coming at that time. And maybe they'll get into a safe place so they don't get hurt. Now, medication-wise, Dilantin is still the best choice for seizure disorders. I know when you look on your medication, Neurontin was once a seizure medication, but then they found out that it helped restless leg syndrome better, but it's still neuro, right? So it started out as a seizure medication. Now, the thing about Dilantin that you need to remember is that you give the medication with food. It can stain the teeth. You can also get gingival hyperplasia. I believe in the book it talks about gingival something. Gingival something, but it's not. But I'm going to call it gingival hyperplasia because what happens is the gingival part of your mouth, the gums, get receded, and it can be pretty bad. You will learn about that in psych because some of the medications cause that. So I want to talk about the management of seizure patients, and that is in your management box 22.1. Oh yeah, here it is on page 372 and under the drug therapy, and it's talking about Dilantin or phenytoin. It says that provide meticulous mouth care to prevent gingival overgrowth. Well, that's just the gums growing over the teeth or receding. All right, so the next page is the management of seizures, which is your management box 22.1. So do remove any objects that could harm. Do turn the person to one side if possible, so to prevent aspiration and swallowing their tongue, so to speak. Do note the time the seizure began and how it progressed, so documentation. Do assess and document post-ictal. What does that mean? Post-ictal. Well, it means a lot of patients after their seizure, they're in an icter. They have icterus. It's a state. It's kind of a blank state. They just kind of stare off into space. Do allow the person to rest quietly. Do call emergency if a generalized tonic-clonic seizure lasts more than 4 minutes because of oxygen to the brain, or if seizures occur in rapid succession. Do not restrain the person unless he or she is in grave danger of severe injury, and do not attempt to force anything between the person's teeth. Now, I know that kind of goes against some things we'd learned earlier about seizures, not earlier in our class, but maybe in years prior. But since then, they've learned some things, some preventative measures. So let's talk a little bit about head injury. So there's different types of head injury. There's the scalp injury, which could be a laceration or a contusion. A concussion that has no visible injury, but you can lose consciousness less than 5 minutes. Contusion is bruising or bleeding in the brain tissue. Now remember what I said the last chapter about the brain. It's trapped in the skull. So whenever you have any kind of bleeding or swelling, you're going to get symptoms. Hematoma can be a collection of clotted blood, subdural or epidural, and we will be looking at some pictures of that. Intracerebral hemorrhage, lesions in the brain tissue, and penetrating injuries, which are sharp objects that penetrate the skull and brain tissue. Not good. So surgical treatment can be done. You can have surgical treatment, and the nursing care, your interventions would be monitor the patient closely for signs of increased intracerebral blood flow, loss of consciousness, pupils. Remember, these are your neuro checks. And then the responsiveness, their motor deficits, or any abnormal posturing, fever. You want to pay attention to their respiratory status. Make sure they're breathing. Make sure their pulse oximeter is reading greater than 92%. Nursing measures to prevent injuries. We talk about that in that health promotion section I just read. The patient who has suffered a head injury may have serious lacerations or abrasions that can admit pathogens. So they would need to be on antibiotics. That would be especially imperative on a penetrating injury, sharp object, dirty object, or crushing blow. And then after a head injury, the patient may have temporary or permanent motor impairment. While confined to bed, the patient should be turned, repositioned, and encouraged to deep breathe at least every 2 hours. Important to know. Another really important thing here is to perform range of motion exercises. So if the patient has an injury, they might have a loss of consciousness, or maybe they're sedated. So, or maybe they have seizure medications that make them sleepy. So they need to be positioned, but you need to position them in a functional alignment. In other words, move their extremities around so they don't get any contractures. We want to move their extremities. Functional alignment means how they move, how they will be moving. Very important to remember that. Also, altered self-concept and impaired role performance. They might look differently if they get an injury to the head. So I will say that health promotion, prevention is the best thing to do. And if you look at your health promotion box, everyone should practice general safety by using the following: helmets for activities like football, baseball, skydiving, snowboarding, and skateboarding, helmets for riding bikes and motorcycles, seat belts in the car, and helmets on job sites at high-risk areas. Okay. Here's just another little review. Now remember, if I repeat myself, I guess it must be important. So nursing care and head injury, inadequate cerebral perfusion, so monitor that level of consciousness. Awake, alert, move all extremities, pupils. Do they answer appropriately? Can they move their extremities? I said that. Inadequate oxygenation, monitor their respiratory status. If they've had a laceration, it could admit pathogens, so maybe they need antibiotics. Potential for infection, they are at risk because of that pathogen. Impaired mobility, reposition to avoid deformities. Cough and deep breathe every 2 hours. Perform range of motion and position, say that 10 times. Position the joints in functional alignment. The altered self-concept related to the loss of function, if they do have that, secondary to the head injury. Also impaired role performance. So this is just a picture. I know it's in your book, but I just wanted to call your attention to not only the subdural hematoma, it's subdural, so it's under the dura, but See how it's pushing the brain? And that's what happens. You get secondary impairments because of it taking up space and pushing in on the brain. And again, it depends on what part of the brain that has been injured. Let's look at the second picture. Intracerebral hemorrhage. So you can see how it's taking up space. So that's going to be pushing areas of the brain and putting pressure. Okay, so now we'll talk about brain tumors. The cause and risk factors, developing in cancer patients as a primary or a metastatic tumor. Invasion can cause increased intracranial pressure. There's no room in the brain for anything. So if a tumor comes in, it's going to increase intracranial pressure. Signs and symptoms will be directly related to the area of the brain that's affected. The things that could be affected would be motor, sensory, visual, or they could have a headache, like that story I told you the last chapter. They may have new onset seizures. That could be the first indication there's something going on in the brain. Medical treatment may be surgical. They could have radiation, chemotherapy, depending on what is the problem. Nursing care depends on the deficits, so would the treatment, and so would the prognosis, depends on deficits. So the nursing care of the patient with a brain tumor. So this is following your interventions. So pain related to the pressure of expanding tumor mass, that headache. Impaired cognition related to the effects of the tumor on the brain tissue. If it's in the area of remembering or speaking, it could affect that if it's in that area of your brain. Remember we talked about the Broca area. Potential injury related to impaired conduction of sensory information. Maybe they're not getting the information, or they're getting the information but they can't send it out, right? Impaired mobility and inadequate self-care related to a motor disturbance. So they can't bathe or dress themselves or feed themselves, toileting. When I was taking Pilates, there was a gentleman there who had been in a ATV accident when he was in his late 20s. He was now 32 when I saw him. He'd been doing Pilates for a couple of years, and when he came in, he could barely walk. He would drag his leg. When I saw him 2 years later after taking, well, he did rehab, of course, but it didn't help him that much. But the Pilates did, and he was actually doing a punching bag with both arms. He was walking, he was talking, he was joking, different person. So I think a very important thing is rehab, and just keep trying to create new synapses, new neural connections. You know, they found that you can do that now. So I would never give up on someone with a brain tumor or a brain injury. So let's talk about infectious inflammatory conditions. Now I'm going to just do a quick rundown of the things we're going to be going through, and then I'll go through each one specifically. So in meningitis, I just wanted you to look at the health promotion, and that's on page 379. So patients with meningitis and those who interact with them should receive the following interventions. Vaccination to prevent pneumococcal pneumonia and influenza. Treatment of respiratory and ear infections. Remember when we talked about ears and the respiratory, that can affect our meninges. Prophylactic antibiotics for anyone in close contact with bacterial meningitis. I know there's an injection some kids need before they go to college, some students need before they go to college. Next thing is encephalitis, very similar to meningitis. It's an inflammation of the brain. Meningitis is an inflammation of the meninges. Guillain-Barré syndrome is an autoimmune response to a virus. I got a great story for that. Parkinson's disease is degenerative with loss of coordination, involuntary motor movement. Multiple sclerosis is a progressive degeneration of the myelin sheath. Now remember, this is just a brief synopsis of each thing, but I'm going to go into each thing individually. Amyotrophic lateral sclerosis, or ALS, is a degenerative neurologic disease. Huntington's disease is an inherited disease, neurologic. Myasthenia gravis is a progressive defect at the neuromuscular junction. Trigeminal neuralgia, you get pain along the trigeminal nerve, which is the 5th cranial nerve. There's a picture in your book, which we'll get to. Neurofibromatosis, types 1 and 2. Multiple nerve tumors, subcutaneous nerve tumors. Bell's palsy is paralysis of the 7th cranial nerve. Cerebral palsy is a loss of motor coordination associated with birth trauma. And then there's a post-polio syndrome. So let's talk about meningitis. So meningitis is the inflammation of the meningeal coverings of the brain and spinal cord. It's caused by a bacteria or a virus. Patients with meningitis and those who interact with them should receive the following interventions. Vaccination to prevent pneumococcal pneumonia and influenza. They should have treatment of respiratory and ear infections. You know, eyes are very close to the brain and the meninges also. So eye infections, anything in the head can affect our meninges. Prophylactic antibiotics for anyone in close contact with bacterial meningitis. And then it talks about encephalitis being pretty much the same as meningitis. So one of the things that's very significant with meningitis and also encephalitis is nuchal rigidity. So that's a stiff neck. And it's not just because you slept wrong on the pillow. I mean, because it's irritated. And I'm going to show you some reflexes that occur because of the irritation of the meninges. Like this, the Kernig sign. So that's the first one. You can see the nurse there bending the patient's knee up. Now they can't lift their leg up. So what happens here is the Brzezinski sign, flexed hips, so B, Brzezinski sign, flexed hips, and when the neck is flexed by the nurse. So the head comes up, the knees come up when the head is flexed, and that's all because of that inflammation, think about it, that around the brain and the spinal cord. So that irritation causes for these Kernig and Brzezinski, and I want you to pay attention to that Brzezinski sign and the Kernig sign. Okay, Brzezinski sign, the flex hips, the hips come up when the nurse brings the neck up, and that, you can imagine it, can't you? That spinal cord being inflamed and the knees coming up, kind of like in response to irritation. So let's talk about Guillain-Barré. So Guillain-Barré is interesting. Patients with Guillain-Barré syndrome report some recent viral infection or vaccination, probably a live vaccine. This apparently triggers an autoimmune response that destroys the myelin sheath around the peripheral nerves. Remember we were talking about a neuron and that myelin sheath that covers the nerves? So slowly the conduction of impulses across it slows the conduction of impulses across the involved nerves. Now, I want to tell you about my story before I go any further, because this patient came in, she was playing tennis. She was outside playing tennis, fine, active lady, young, and all of a sudden she couldn't walk. She couldn't move her legs. Then it started moving up her body. So it starts at the feet and moves up. So that's why the inadequate oxygenation becomes very important in this syndrome, because this viral infection starts inflaming the myelin sheath, and it starts from the bottom, goes up, and it went all the way up to her head. We had to put her on a ventilator, and she couldn't close or open her eyes either, so we had to tape her eyes shut. We had to keep her on the ventilator until this virus got out of her body. And then it starts resolving from the top down. So slowly she was able to open her eyes, and then we got her off the ventilator, and then we were able to move her arms, and then we could move her legs. Now granted, this can go on for a couple of weeks. So if the patient's been deconditioned for 2 weeks, they're going to need physical therapy. So that's my story about Guillain-Barré. So let's look at it in the book. So it's an acute inflammatory polyneuropathy, autoimmune from a viral infection. There's 3 phases. The initial phase, when they start exuding symptoms, the plateau, where it may not get any worse, and then the recovery, where they start recovering, where it starts going back down and they get better. So the disease process may affect cranial nerves that results in visual and hearing disturbances. The muscles of respiration might be affected. So they require close monitoring because it can go slow, it can go fast. I came in one day, she was not on the ventilator, next day on the ventilator. So close monitoring of these patients. All right, the medical diagnosis, it's just characteristic, ascending from the feet up, motor involvement. Medical treatment, it's autoimmune. So plasmapheresis, we've talked about plasmapheresis before, where they take the patient's blood out and replace it. It's centrifuged and returned to the patient, hoping that the antibodies get triggered. All right, so signs and symptoms I told you about, the initial plateau and recovery. So interventions, and these are in your book under the patient problems, goals, and outcome criteria. So we're going to kind of concentrate on our care plans. So inadequate oxygenation. So some patients require ventilator when it starts ascending up to the respiratory nerves. So closely monitor them for signs of respiratory distress. Respiratory rate greater than 30 breaths per minute. Abnormal chest and abdominal movement. Signal. Problem. Turn the patient every 2 hours. They might need suctioning because that swallowing reflex, that may go too. Be alert for cardiac dysrhythmias due to inadequate circulation. And of course, the potential complications of immobility. So if they can't move, it's up to us to move them and keep them in careful positioning, emphasizing joint movement. So anytime you've got someone in a coma or unresponsive, you want to, because if they may come back, right, you want to have them to be able to go to rehab and get better. We don't want contractures. No excuse for that. Elevate the head of the bed 30 degrees before feeding them. Now, if they can't swallow, they may need nutrition by TPN or a tube, temporary tube feeding. But when they can eat, be sure you elevate their head. Potential for injury because of the progressive weakness. What if they didn't get to the doctor in time? Anxiety. So that progression, can you imagine laying in bed and just feeling, not you wouldn't feel it, but you'd know that slowly creeping up, you're going to not be able to move? That's kind of a scary thought. All right, complementary and alternative therapies in your book, strategies to reduce anxiety, which they feel, include music therapy, some headphones, nice music, massage, the touching, soft touch to the skin. Valerian is used for some people as a sedative. It says the safety is under study. All right, so once their function comes back, you can start the rehab process. Now, this is some clinical manifestations of Parkinson's. That's the next thing we're going to be talking about on page 383. So notice how this person looks, and have you seen someone like this? A forward tilt of the trunk, rigidity and trembling of the head. One thing they didn't mention here is something called a Parkinson mask. Their face is kind of blank. If you know someone who has Parkinson's, they have like a blank look. Their face changes. It's really quite amazing or interesting, however you want to say that. Reduced arm swinging when they walk. And that is one of the tests. I'll tell you this, my brother just got diagnosed with Parkinson's. And he went to a neurologist, and one of the tests they did was the arm swinging. So they lose that. They lose their balance a lot. And that's what took him to the doctor, was he couldn't stand up and keep his balance. So rigidity and trembling of extremities. That was the other symptom he had, was his leg was just like always jumping for no reason. A shuffling gait is very indicative of a Parkinson's. They take short steps and they shuffle. So shuffling gait, the mask, very Parkinson's syndrome symptoms. Anybody know a couple patients that have, or a couple of people in real life that have Parkinson's? There are a couple, I know you know of them. Michael J. Fox has Parkinson's. And also Muhammad Ali had Parkinson's disease. So there's a couple of famous people. No one is safe. So Parkinson's disease is a progressive degenerative disorder of the basal ganglia that results in eventual loss of coordination and control of involuntary motor movement. It's generally recognized as a disease of older adults, but it appears in individuals in their 50s. I think Michael J. Fox got his in his 40s, maybe even sooner. Affected men more than women. It's decreased levels of dopamine. Now, we've talked about dopamine. We've talked about the drug dopamine that raises the blood pressure, but there's a dopamine, which is a neurotransmitter in your brain, and Parkinson's patients have a deficiency of that neurotransmitter. So the cornerstone of therapy is the use of L-DOPA. L-DOPA can cross the blood-brain barrier, and it's converted to dopamine in the basal ganglia. So they have to have a replacement dopamine. Now, Parkinson's is not curable, but you can treat the symptoms. So if you give dopamine, you can thereby supplementing levels of the neurotransmitter and reduce the symptoms of the disease. Now I want to jump over to the third square there, where it says because the benefits of L-DOPA tend to decline after about 2 years, various other drug combinations may be used to control symptoms. Be sure to let your patient know Sinemet combined with another drug increases effectiveness. So what that means is your patient, sorry, I dropped my water. Your patient is taking the medication, the L-DOPA, and they seem to be improving a little bit, and then they kind of level off and don't seem to get better at all. Then they get depressed. Now, Parkinson's patients tend to be depressed anyway, and it says that talks about that in your book. But this makes them even more depressed because they think their symptoms are going to get worse. They're getting worse. And because they know this is, all these things are coming, and they can get really depressed. But if you let your patient know that there's another drug that they can try in addition to L-DOPA that maybe help them and become more effective. That gives them a little bit of hope. So be sure to let your patients know that. And they can talk to their doctor. Now, looking at our nursing care of the patient with Parkinson's on page 384, which is where the picture is. So I talked about the medication, which is really important for you to remember. The benefits of L-DOPA tend to decline after 2 years, but other drugs can be added to help them. And it is a degradation of dopamine in the brain, which is what Parkinson's is. Focused assessment. So beware of the dysphagia that goes with Parkinson's. The health history of a patient with Parkinson's should specifically include assessment for weakness, fatigue, muscle cramps, and sweating and dysphagia. So that's why I put that middle square there. They're subject to inadequate nutrition because of swallowing problems. So what do you give them? Thickened liquids. I know you probably wanted to say frequent small meals because that's what we've said in the past for other problems, but in Parkinson's patient, because of the muscle and nerve condition that they have, thickened liquids will help them swallow. For some reason, water, they'll choke on water, but a thickened liquid they can swallow easier. All right, impaired mobility. Oh, let me go to the next slide. I think it's there. So impaired mobility is really, really important in these patients because it's going to be progressively impaired. They need assistance, they need encouragement, they need to try to take care of themselves as much as possible, as long as they can. One idea is scoot to the edge of a chair before trying to stand up. Use satin sheets. Oh, yay! Finally, a good excuse for satin sheets to make it easier to move in and out of bed because they have impaired mobility. Satin sheets, have you ever been on one? You just slide right on or off. March in place before starting to walk. That's a good idea. They get that movement going before they take off and walk. Practice lifting the foot as if to step over an object on the floor to initiate walking. So they need to be encouraged and reminded how to walk, so to speak. So remember the thickened liquids, the satin sheets. Under complementary and alternative therapies on page 385, it talks about St. John's wort is used widely as an antidepressant. It is a monoamine oxidase inhibitor and can interact with prescribed drugs. Ask the physician to report use of herbal remedies to the physician. So once again, we always want to know if our herbal medications interact with our regular medications. Okay, if you turn the page to page 386, it's still talking about some patients with Parkinson's, the health promotion box. So patients with Parkinson's and those who interact with them should receive the following. And I know I've mentioned this before. Maintain a general health and regular checkups. Follow a regular routine of stretching and exercise to maintain mobility and balance. I need to tell my brother he needs to start physical therapy to stay strong, right? Prevent falls through environmental control. All right, let's move to multiple sclerosis on page 386. So what it is a chronic progressive degenerative disease. Multiple sclerosis attacks the protective myelin sheath around the axons and disrupts the conduction of impulses through the central nervous system. You can see that on figure 22.5, and I do have it on the next slide as well. So that gives you a good look of the sites in the brain. There's little lesions in the brain. Patient will get an MRI from time to time to see how the progression, if they are progressing or staying the same, because it does go through exacerbations. It can progress and then stop for a while. So the disease may progress steadily, chronic progressive MS, but it may also be characterized by exacerbations and remissions. So their symptoms decrease and they get to do more things. They need to balance time among rest because they can get really tired easily. So balance time among rest, work, and family. There usually is, or there may be, a familial history in the family. Maybe someone else had multiple sclerosis. That would be great when you're taking a history. The condition worsens during hot weather. That's been found to be true. Treatment, medical treatment. Because of the chronic progressive nature, the treatment of MS is symptomatic and supportive. Drug therapy during periods of exacerbation may involve adrenocorticotropic hormones, or ACTH, corticosteroids. Sometimes they may need to be put on immunosuppressant drugs, and those are also used during exacerbations. But remember, if you're on an immunosuppressant, you've got to be careful being around people with infections, because that lowers your immunity. So these patients should be protected against anyone who is sick. It also talks under medical treatment about urinary retention is treated with cholinergic drugs like prostigmine, and spasticity of the bladder can be treated with anticholinergics. So here's the picture I was talking about that's in your book. Common sites of multiple sclerosis lesions in the brain and brain stem. And where those lesions are is where basically the patient's going to have the problems. And you can see the myelin sheath damage, which leads to their physical problems. All right, so I want you to notice the health promotion box on page 387. Patients with MS should receive the following interventions. Maintain general health through diet and exercise. You really need someone who's motivated. They need to want to get better and stay better. And that is an awesome trait in a person. Avoid or minimize effects of triggers for MS, such as infections, trauma, climate changes, and immunizations. Also seek regular medical checkups for disease prevention. All right, so this is just another reminder. I just talked about the health promotion box on page 367. I just read that to you. So because the initial symptoms typically occur in young adults, patients, I'm repeating it again, aren't I? That must be important. Patients often must learn to balance work, home, and family responsibilities. Provide the patient with opportunities to talk about their illness. So also take a look at your care plan on page 387, impaired mobility related to weakness or spasticity, potential injury related to neurologic impairment, inadequate self-care. They may need help taking care of themselves, ADLs. But it's good to encourage them to be as independent as possible. It's great for their self-esteem and it's great for them. And then you just help as needed. Ineffective urinary elimination, so they might have a problem with that. Potential for infection, so absence of infection, normal body temperature, and keep track of their white blood count. Also on the next page, it has inadequate coping because they have to adapt to their changes in their body and their activities. Inadequate knowledge. Knowledge is power, as we know, and they should know about their disease, their treatment, and their self-care. It makes them more powerful if they can take care of themselves. Okay. Now let's jump to another neuro disease. Amyotrophic lateral sclerosis, or ALS. Now, it's also known as Lou Gehrig's disease. He was a baseball player. It's a degenerative neurologic disease. It affects males 2 to 4 times as often as females, and most often strikes those between 40 and 70 years of age. But now, that's the general rule, but always remember, it can happen before. Also, despite involvement of the motor nuclei of the brainstem. Now, this is really important to know because these patients, their body gives out totally. And I'm going to tell you a person that you can picture, and this to be true, and this is how you can remember it. So, Stephen Hawking. Do you remember him? Have you heard of him? He was a very, very intelligent man. If you saw the movie Theory of Everything, it was about Stephen Hawking. It was his life story. I would recommend, if you haven't seen it, to see it. He was studying in England. He was a very, very smart man, way over and above everyone. So his brain was great. He had great potential. And then he gets the disease. And so that's why I'm saying here the intellectual ability, sensory perception, vision, and hearing are unaffected, but their body gives out. So if you see this movie, he starts out as a young man in college, walking around. He begins to trip. So his body begins to start to give out. And then at the end of his life, now Stephen Hawking lived longer than anybody else ever has with ALS. Maybe because he had the money to support, I don't know, but he did have, and in the movie, I don't want to give it away, but in the movie he gets pneumonia and he has to be on a ventilator, and that's one thing. He did get married and have kids too, by the way, but his wife has to decide, should he be put on a ventilator? Because he was in a state where his body was just useless. He had his brain though. So she knew that, and she didn't want to take that away from him. And he went on to write numerous books about black holes and way smart things. So anyway, his intellectual ability was not affected, but his body gave out. He ended up in a wheelchair, all crippled up, just like sitting on the seat. But his brain was good. There is no known cure or treatment for ALS, so therapy is supportive. Focus on the prevention of complications like pneumonia and maintenance of maximum function. So rehab would be a good thing for them. The thing about ALS, as I said, you know what this diagnosis means. You are going to be crippled for the rest of your life. It's going to just take away all your bodily functions. All you'll have is your brain. So you suffer something called anticipatory grief. You know what's going to happen. So once the implications of a diagnosis of ALS are understood, patients and their families may begin the grieving process, grieving for the loss of what they're going to have. But you need to encourage patients to talk, listen compassionately to them, and help them to make realistic plans. And just always remember the stages of grief. It can be anger. It could be, why me? Why me? So remember the stages of grief. Explore the patient's thoughts, feelings, and concerns about living with this progressive terminal illness. Although it's difficult not to offer false reassurance, let the patient cry or otherwise express grief and anger. Stress the patient's strengths, abilities, and contributions, and identify and enlist sources of support, family, friends, support groups, spiritual counselors, therapists. You can use stress-reducing techniques like imagery, guided imagery, breathing exercises, progressive relaxation. To preserve the patient's dignity, it's important to provide privacy during personal care and to help the patient attend to grooming and appearance. So important here is that that it is a progressive terminal illness. They will grieve for that. And there's a cultural consideration on page 380. Patients facing progressive incurable illnesses may find comfort in religious symbols, charms, incense, candles, and native healers. And remember, we always have to be accepting of what they think will help them. So just remember the grieving that they will encounter. Okay. Myasthenia gravis. Now I know Huntington's disease is next in your book. It's an inherited degenerative neurologic disorder. It usually begins in middle adulthood with abnormal movements. Symptoms progress steadily with increasing disability and death in 15 to 20 years. So it's a short little blurb about Huntington's disease. So myasthenia gravis is a chronic progressive disease in which a defect exists at the neuromuscular junction where electrical impulses are transmitted to muscle. So you can see what's going to be triggered first. The muscle is going to be affected by this neuromuscular disorder. So there's interference of acetylcholine receptor sites. They think it has an autoimmune basis, so it could be an autoimmune type of disease. To make a diagnosis, they do a tensilon test. If you want to read about that, I believe that's on page 391 under medical diagnosis. This is how they diagnose myasthenia gravis with the what they give the tensilon, and it increases the ACTH, the acetylcholine receptor sites, and they get better during this test. So the muscle tone improves. Corticosteroids can be useful in this disease. Also, the thymus gland can be affected because many patients with myasthenia gravis have hyperplasia of the thymus gland. Thymectomy is performed early after the initial diagnosis. Plasmapheresis is another therapy that's used, and that's because they think it's autoimmune. All right. Corticosteroids can be useful. Emergency respiratory support in a crisis. So there is something called a myasthenic and cholinergic crisis. It presents with sudden extreme weakness and respiratory impairment. So got to catch that right away and get them help. Because myasthenia gravis is a chronic neurological disease, the patient is generally managed at home. And basically, nursing care of the patient with myasthenia gravis, adequate oxygenation, drug therapy, mechanical ventilation, impaired mobility because of inadequacy of their muscles and nerves to work, so they can't have difficulty dressing, inability to communicate. They may have weakness of the muscles in speech, so they have difficulty communicating. Inadequate nutrition. They have difficulty chewing and swallowing. Teach the patient to lower the chin toward the chest when swallowing to help prevent aspiration. And of course, again, knowledge is power. So if they know about the disease, they can know what to anticipate. I guess it can be a blessing and a curse. The more you know, sometimes the more you might get upset. if you're that kind of person, but also some people, the more you know, the more you want to do to get better or to prevent getting worse. As you notice, a lot of these diseases, they just don't get better. All right, we'll go on to, oh, I did want to go through this, sorry. So this is a care plan. It's in your book. Yes, I copied it right from your book. Inadequate oxygenation related to impaired conduction of nerve impulses. You want to get a respiratory rate of 12 to 20. Impaired mobility, so you want to improve the mobility and self-care, performance of ADLs without excessive fatigue. They might have an inability to communicate effectively related to weakness of the muscles involving speech. So maybe do another form of communication if their speech is a problem. Maybe a board. Did anybody watch Breaking Bad? It's funny that I asked that, I'm sorry, but the grandfather, I guess, or the older gentleman, he had a stroke, but he had an inability to communicate, and he used a bell. And he used a bell, one ding was yes and two dings was no, or vice versa, I can't remember. But a bell could be used. He also used a way with the communication with the nurse. I'd never seen this done. If this was interesting. She would go A, B, C, D, and then he'd ding his bell when she got to the right letter, and then she'd go across the other direction of which letter would be next, and then it would spell out a word, and then she'd write it down on a board and find out what he meant by that word, or maybe it told her what he needed. So that's another way. They also have boards with pictures on them that the patient can point to of something that they need, or you can point to a picture and ask if that's what the patient needs. And then, of course, knowledge and nutrition. We want to maintain a stable body weight and no respiratory distress. Remember that muscle weakness in the swallowing can lead to aspiration, so we want to prevent that. And this is in your book. This is just a picture of the acetylcholine not being able, the neurotransmitter. As you can see, it just doesn't connect up to the receptors. And this is in your book on page 391. So neurotransmitters, norepinephrine, epinephrine, acetylcholine, and dopamine are released from the axon. They travel across the synaptic cleft and produce some responses. In MS, weakness, chewing, and speaking can be affected. Right, let's talk about trigeminal neuralgia. So that's on page 393. Trigeminal neuralgia is characterized by intense pain along the distribution of one of the three branches of the trigeminal nerve. That's located right about at the ear level, and it branches out. You'll see a picture in your book of figure 22.7. It affects many nerves in the face, optic nerve, maxillary nerve. It's also called tic de la rue. That was another name. My grandmother had this. Intense pain that they get. I'll also tell you, if you look this up on Google, it's a suicide disease. They used to call it that. This was before they knew a lot about it. So the patient is in such pain. It's so painful. Intense pain along the distribution of the three branches of the trigeminal nerve, or the fifth cranial nerve. So ophthalmic, mandible, and maxillary. The pain has an abrupt onset, so there's no warning, and it's usually unilateral, meaning on one side, and it lasts from seconds to minutes. Trauma or infection can precipitate the pain, and these patients can be treated with Dilantin. Let's see. Here's a picture of the divisions of the cranial nerve, which is in your book. It talks about pain related to disease process, so you want to make the patient comfortable. Inadequate self-care related to debilitating pain. It can be so bad they just curl up, don't want to do anything. And they might have inadequate nutrition because they're so pain they don't want to chew. It hurts to chew, so they don't get enough nutrition. And then they have a fear. If it goes away, they have a fear, when's it going to come back? Inability to perform self-care related to lack of knowledge of trigeminal neuralgia and its treatment. So the patient needs to understand about their disease. Cerebral palsy. Again, anybody watch Breaking Bad? If you did, the child of Walter White had cerebral palsy. He walked with 2 canes, and it was from injury at birth. Hypoxia, birth trauma. So what cerebral palsy is it's a paralysis usually associated with a loss in motor coordination caused by cerebral damage. So they're not always, don't think of them as having a mental, in this movie, he was very smart, this young man. He was 16. He'd learned to get around and take care of himself, and they can. So it doesn't affect their brain. It's just that their body suffered from a lack of oxygen at birth. So cerebral palsy.